morning, everybody, and thanks again for taking the time today to share these things with us. I am a surgical oncologist, which means I'm trained in general surgery. Specific focus on cancer with very lucky and we're here have 7 years with patients about how much we're still learning today, how much changed. And I was invited to speak about something that might not associate with surgery, but surgeons have played a big role in the development of these research efforts and technologies. And I'm going to talk about intralesional no relevant exposures in relation to what we'll talk about today, although I will be mentioning some different clinical trials and proprietary agents. We'll try to do it in an agnostic fashion and just give you a general overview of our experience at Huntsman and how it applies here for other patients. I want to start by talking about a little bit of what I mean by intralesional therapy, definition, history, and then review some of the indications for these types of new treatments, and then discuss some examples of these agents, there's different types, and then go over some case studies at the end to sort of illustrate how they can help patients. So I like to think about this as the golden age of melanoma therapeutics, and people may disagree with me, but when I was in my research fellowship in 2005, the median survival for patients with metastatic melanoma was actually around 6 to 9 months at most, meaning there was no effective therapy for patients that did metastatic melanoma. And it prompted a lot of research to kind of change the way we think about people with metastatic cancer and looking for major breakthroughs. I'm really fortunate to work with the auspices of Steve Rosenberg, the NCI, who introduced me to immunotherapy, and a lot of the concepts that have been learned over the last 100 years from manifested in the last 10 years, we're lucky to be exposed to that and prompted my interest in melanoma care. And Dr. Hulis has been described the survival for patients today with metastatic melanoma on average now 24 months. And that may not seem like a huge jump, but in cancer therapeutics, that is a huge jump in just a short amount of time. And since 2011, there have been at least 10 new agents that have been approved by the FDA for treatment for stage 4 melanoma. Prior to that, there were only 2, and again, none of which have been shown to actually improve survival for patients in the long term. And what are we talking about? The main thing is systemic immunotherapy, the major breakthroughs in treatment that all patients, most patients can receive, and mainly relying on what's called checkpoint inhibition. As Stephen discussed, these are antibodies that are given in an infusion and IV to patients, and you take the brakes off your own white blood cells to get them to recognize and correctly kill tumors. So it's not directly killing the tumor itself, giving your body to do the work for you. And we've had a lot of success with agents such as Ipilimumab, which works through the anti-CTLA-4 mechanism, as well as the Nivolumab and pembrolizumab, mechanism as well. And then concurrently with that, there will be major development in what we call targeted therapy. Those are treatments designed to muck up the machinery of the cancer. Specifically, what I'm talking about is for patients who have what's called a BRAF mutation. They're eligible to receive pills that can actually target that mutation and shut the tumor down and cause rapid decrease in size of those tumors. We've seen some really incredible responses. Patients where we thought were very close to death and rescued by these wonderful treatments. However, these things do come with problems, and Stephen discussed that only about a third of patients will respond to first-line immunotherapy. I mean, 2 out of 3 actually don't and move on to other treatments. And only half of all patients who have melanoma have this BRAF mutation that I just mentioned. And so for the other half, they can't even exhibit the benefits of having the targeted therapy. And there's no free lunch with anything we do. I'm a surgeon, so I get to see the bad things I do to people at night and on a daily basis. And in that cancer, we can also cause a lot of problems with systemic cancer as well. And many of you may have undergone treatment where the adjuvant for metastatic disease may have seen some of these rash, fever, colitis, inflammation of colon. inflammation in your liver and lung, and then hormone imbalances, some of which can be permanent, and very rarely can lead to death. And how do you treat difficult tumors like these? I don't mean to wake people up this morning, but I wanted to show some of the things that surgeons that we see in our clinic. These are patients who may or may not have been treated for the melanoma before, but have had recurrences of their cancer in and around their limbs or their trunk or their scalp, where you can actually see the tumor coming back. And when I look at that, those things don't look like you can treat those with a knife. Some of these lesions are very painful, and many do not respond to systemic treatments. And again, surgery is often not possible or effective. So we've got to find some other alternatives for that. And also, when we try standard systemic treatments and they fail, what do we do next? This patient has a large progressing tumor in their axilla that you could very easily see from across the room, and also metastasis in their adrenal gland, amongst other places. When our standard treatments don't work, what can we do to manipulate things to get them to work? And that's where intralesional therapy may play a role, and we're learning more about it moving forward to help in those situations. So what do I mean by that? Injecting treatment directly into the tumor. There's a variety of agents that I'll discuss shortly with this treatment and their potential benefits. When you inject substance directly to the tumor, it goes directly into the tumor. It doesn't go into the IV and potentially can reduce toxicity related to that treatment, depending on how it's given and what the other agents the patient are receiving. You can also potentially destroy the tumor directly. Actually, some of these agents are known and were first found to have been effective just simply by injecting right into the tumor itself and watching it go away in front of your eyes. And then ultimately, the biggest thing is the potential to overcome the resistance to systemic immune targeted therapy failure or rescuing patients where those treatments don't work. Somehow making these tumors more responsive to the systemic therapies, which we already know work. What am I talking about? In patients who have tumors that don't have a lot of the cytotoxic T cells, which are the killer T cells that have infiltrated them, we know that they don't respond as well to systemic immunotherapy. How can we get them to do something to them or to the environment around them to get those T cells actually into the tumor itself so that the patient can respond to their white blood cells can recognize them and destroy them? Which patients can get these types of treatments that we can inject in tumors? Not everybody can. You must have an accessible tumor, and really that just means you put a needle in it. It's as simple as it gets, whether it's on the skin, under the skin, or sometimes increasingly these days there are studies looking at ways to under CT or ultrasound guide deliver therapy directly to the tumor. As long as you can access it, that's the primary thing that you need to know. Also, the tumors to this day cannot be removed surgically, meaning when the patient comes for these treatments or we think about them, they've gotten beyond the point where we think surgery is effective for them. In other words, if you came with an isolated lump and that was found to be melanoma, we oftentimes don't use these treatments up front, especially if the patient hasn't seen other therapies, because surgery still has an effective role for these patients, and there are effective treatments after surgery that can try to prevent them from coming back. And in many cases, other treatments must have failed before you can be enrolled in a clinical trial or even use standard of care intralesional therapy. Many times people, and you should really strongly consider using other treatments that have been shown to be effective systemically first. The different types of intralesional therapy. The first type described involve basic bacteria or bacteria-like substances that were injected into the tumor. We're also going to talk a little bit about oncolytic viruses, which some of you are familiar with here in this room. And then other types of intralesional therapy using other types of molecules. This field dates way back to the 1890s. It's a sarcoma surgeon named William Coley who reported in 1891 that he was able to induce tumor shrinkage by injecting the live streptococcal bacteria into a tumor. And actually he went on to develop these toxins, Coley's toxins, where he would mix live streptococcal bacteria with serratia. These are things we would not want to have injected directly into the tumor. And in fact, he would titrate and he would change the dose and make the infections go up to the point where the patients were having fevers of 102 to 104 degrees fever. So making the patient sick to induce an immune response. And miraculously, some patients, that was all that it took for the tumors to shrink and go away. And while the mechanisms weren't well understood at that time, people definitely understood that you can inject substances into the tumor, cause inflammation, and get those tumors to shrink. More recently, in the 1970s, another surgeon, John Morton, first described the NCI using what we would know as BCG, which is essentially a vaccine that was developed for TB that's still used in certain parts of the world for it. And actually just injecting that modified bacteria into tumors can cause necrosis and destruction of the tumor in up to 70 to 90% of patients. And also there were some lesions that weren't even injected that shrunk as well. And this gave some credence to the thought that the therapies themselves can induce a bystander effect. Other lesions can shrink just by injecting those treatments alone. Today, one of the more frequently utilized intralesional therapies revolve around manipulation of viruses. And melanoma virus is a parasite that can only live inside of living cells, and they selectively reproduce in humans and do things like cold or HIV. And recently, scientists have been able to come up with modifications of some very common viruses that can help us treat cancers and selectively infiltrate them. They're attractive because if you modify viruses, you can make them so that they don't cause the side effects or problems that you would normally associate with that virus. A lot of them can be selective to only infect tumor cells and then grow rapidly inside them, causing immediate tumor destruction. And they can be modified to add things to them, almost like a Trojan horse, where they would be transcribe and make proteins that would allow for an inflammatory response in a tumor that was unable to do so prior to that. And also, they've been associated with non-injected tumor response that bystander effect described. The first FDA-approved oncolytic virus that was shown to have efficacy in a large clinical trial is something called T-vec, or talimogene laherparepvic. You got that right. So we all know it as T-vec, and a lot of work was done around the United States. Several clinical trials were opened here at Huntsman by my former partners. And this drug is an exemplary version of these types of oncolytic viruses, and that it was modified so that it wouldn't cause the standard herpes simplex cold sore or systemic problems, and selectively infiltrate tumors, cause tumor lysis, and then with that inflammatory response, also uninjected lesions were also shown to shrink as well. And that showed effective durable response for some patients as treated on those clinical trials. There have been other viruses that have been utilized. HF10 is also a herpes virus. There's a common cold virus, a Coxsackie virus, that's been utilized in some clinical trials, as well as common adenoviruses. Again, some of which were modified to allow substances to induce inflammation. Other types of intralesional immunotherapy include proteins or peptides that stimulate inflammation and T-cell activation. IL-2 or IL-12 or cytokines are small proteins that can cause T-cells to grow or to be activated and that can be injected into tumors or in combination with other treatments. And then the toll-like receptor or STING pathways also are cellular pathways that have been manipulated by proteins that are injected into tumors to cause inflammation, essentially getting tumors where the cells around the tumors to be primed in a better way, be more inflamed, get T cells to be more active to go and destroy the tumor. There are some limitations to this, and I cannot emphasize this enough. I make things sound great on the slides, but these treatments don't work for everybody, and maybe only a third of our patients with advanced melanoma have accessible tumors that can receive this type of treatment. And we know that the solitary use of the treatments, these treatments, meaning only these therapies alone, are not as great as we'd like them to be. There's really excellent responses in lesions that are directly treated. Reports from 60 to 70% or more of those lesions shrinking with a variety of agents being directly injected into them. But really mixed or minimal response in non-injected lesions, especially ones in the liver, lung, far away from where you're injecting these substances. really needs to be utilized in combination with other treatments. To date, none of these treatments is associated with use or improvement of overall survival alone. There's been some hope that in combination with other treatments they'll help improve survival. They've not been shown to be superior to the systemic immunotherapy that has been utilized today. There are side effects, and I can't minimize these either. Patients, obviously the ones reported to us, pain, fevers, chills, almost feel like you have the flu when you get the injection. Some people will report that. And there can be breakdown of the skin overlying these injection sites and necrosis sometimes. And the cost. Some of these agents cost tens of thousands of dollars. And so, obviously insurance covers some of these things, but patients have different types of insurance plans, different co-pays, and all this comes into the decision-making for patients. So, and currently, in looking ahead in future applications, I talked about combination immunotherapies, mixing these with systemic treatments. There's many trials that are looking into this. And then also what we call neoadjuvant approaches. For tumors that we know we're going to remove surgically, how can we manipulate them to potentially make the recurrence risk for patients much lower? Just going to finish off in the last couple of minutes looking at a few patient examples. So I mentioned BCG, the bacteria, the TB vaccine that was injected in an elderly patient of mine who couldn't undergo systemic treatments, who had really painful lesions on her foot. And after 6 months of treatment, these went away and she was able to walk and got good affiliation from this. Got a patient who occurred very quickly after a big surgery did on the side of her scalp with transit lesions that we couldn't remove surgically, and after 10 weeks those completely disappeared and she's disease-free. We've got other patients with much more advanced disease on the scalp where we've been able to introduce DNA that can code for these cytokines that can produce inflammation, and they've been able to have some really dramatic responses in really difficult to treat areas. And then also in the combination of these viruses with systemic treatment, getting lesions that really were difficult to treat on the arm to go away and stay away in the patients on disease-free for about 5 years now. We have many active studies open at the Huntsman, both phase 2 and phase 1 studies, and we're looking to open more in this promising field. I just want to conclude that I'm very happy with the direction we're going with modern melanoma therapy, but we need to make a bit more improvements. Intralesional therapies offer both direct and indirect treatment benefits to successful tumors. Emphasize not everyone can get these treatments, but for select patients, this may be the right way to go. And combining them with other treatments will be the future for this. Thank you. As I end here, I just want to say thank you. A lot of these studies to look through some of these viruses were done in part with contributions from patients from the Huntsman Intermountain Medical Center. Without your help, we would not know how to use these treatments, and we would not be able to make these breakthroughs. And so I have to offer heartfelt thanks to all of you. Thank you.